Welcome to Facebook Friday. My name is Kate Wakelin and I'm from Neuroendocrine Cancer Australia, and it's really wonderful to be beaming into your home from my home, and I know that everybody is all around Australia. It's Wednesday the 17th of July, and we're very happy to have a special guest with us, and I will introduce Lorraine properly in a moment. But before I go any further, I'd just like to acknowledge that I am streaming to you from Wurundjeri land, and that's the land of the Kulin Nation. And I'd just like to pay respects to elders past, present and emerging. I also always say this, but I love to run along the Yarra River, which runs very close to my house, and that's the Birruang in our local language, and so I'm just full of gratitude for that. So just briefly before I introduce Lorraine, I do want to give a brief update about coronavirus, and that really there's not a lot to add from previous weeks. We're seeing some clinical trials emerge, and interestingly, we heard last week from Professor Tim Price, and Lorraine will also be telling us some things about clinical trials in sorry, beg your pardon. I think I might have said the wrong day. It's definitely Friday. So Lorraine will also be talking with us about clinical trials in cancer, but we've got this parallel process at the moment where a lot of people are paying attention to clinical trials in coronavirus. So that's a really interesting thing to observe. The other thing just to know for those of us who are in Victoria, and I am in Victoria, so the numbers are really seeming to be quite high this week. And I guess it's a reminder to everybody that even if the virus doesn't appear to be very prevalent in the community where you are, the virus is incredibly infectious and spreads really quickly, and so we all need to be vigilant about hygiene. But there's increasing advice coming out about masks, and we did put some information on our website directly from Cancer Council, so if you haven't caught up with that, I'd really urge you to do so. And I'll put another note in the notes referring to that information about not only the type of masks that would be good to wear, but the situations where they should be worn, and really importantly, the way in which you should wear them, because if we know if they're not used correctly, then they're not going to be particularly useful. So I'll just draw your attention to those things and put the links in the notes for you to have a look at afterwards. So I'd like to introduce Lorraine to you. So Dr. Lorraine Chantrill, she's coming to us with a couple of different hats on, but firstly and foremostly, probably the main reason we're talking with Lorraine is she's actually the chair of AGITG, and I'll get Lorraine to explain AGITG. When I first came to cancer, I was amazed by the plethora of acronyms. So AGITG is one of them that is around in neuroendocrine tumours language, and so Lorraine can explain what that means. Lorraine's also a medical oncologist who works with people with NETs in regional Australia, so as well as being a translational researcher, and she can explain a bit more about what that means as well. So there's lots of reasons why we're really excited and grateful to Lorraine for joining us today, and thank you, Lorraine.
Thank you, Kate, for having me, and hello to everybody around Australia who's dialing into this short video. I'm very pleased with the way in which this technology can connect us with all of you, and perhaps this is one of the good things that's come out of this COVID period, is that perhaps we'll be embracing this type of technology much more in the future. It's a really good use of this platform to be able to talk to quite a few people at once, and hopefully I'll be able to answer some of your questions. As Kate said, I chair the AGITG, which is a trials group for gastrointestinal cancers, and because many neuroendocrine tumours occur in the gastrointestinal tract, we actually take those tumour types on, and we have clinical trials for people with neuroendocrine tumours and neuroendocrine carcinoma. So it's a really exciting part of our work, because it's obviously helping people with a rare tumour type, and it requires quite a lot of expertise. So trying to get some of these studies out to people like yourself who may be in regional or rural areas is a really important thing for AGITG to do. I also work as an oncologist. I'm very privileged to look after people in the Illawarra area of New South Wales, and also the Shoalhaven, where we see a more rural population. And as Kate said, I also like to do some laboratory-based work. No longer myself, unfortunately. My days in the lab were some of my happiest days, but I don't have the opportunity to do that myself anymore. But I work with some really clever people who do some excellent scientific work, and I just help them with clinical questions. So I'm hoping that I can be of some use to you all today by answering your questions and by answering Kate's questions. I think she has a few up her sleeve for me. Shall we go ahead, Kate?
Yeah, that sounds great, Lorraine, and thank you so much. And yeah, if you've got questions along the way, you're welcome to put them into the comments box as we talk, and we'll see if we can weave those in. So Lorraine can't see the comments, but I can see the comments, so we'll see what you come up with. But there were some questions that came in for us, so yeah, I'm going to start with those, and we'll see where it all takes us. So can you tell us a little bit more about your role with an AGITG? So you mentioned it's a trials group for gastrointestinal tumours, but how do you fit into that picture?
So I guess personally, I started attending their meetings, and as a young medical oncologist with research ideas, I was very enthusiastic, and I came up with trial ideas which I wanted someone to hear and help me achieve funding for. So I've done that a couple of times. I have to say I haven't always been successful. I think most successful scientists have a long list of failures. I have a similar long list to some of my colleagues, but I think when you're working as an oncologist, what's really wonderful is if you may not be able to solve all of the problems for the people in front of you at the time, but being able to say, I'm sorry, I can't fix this for you now, but we do have this great study that maybe we could consider that might not help you necessarily, but might help people in the future. That's a really wonderful thing to be able to talk about in a clinic, and to be able to provide patients in front of me with a sense of altruism to help others, and to provide hope for them themselves, and really to just say that we're not just sitting back treating people all the same, that we're actually thinking ahead and thinking how we can actually do things better. So that's where my love of clinical trials comes from, is really trying to progress the field for the people who are in front of me in the clinic.
And Lorraine, I think that you touched on a really beautiful point that I see, a wonderful aspect that I see in patients when they talk about clinical trials, which is this, certainly that hope that there might be something that would help them and managing their disease, but more broadly, that generous spirit that we see where patients want to really contribute to the well-being of people who are going to come in their wake. And I just think that's amazing. So
yeah, and you know what, we have developed very close relationships with consumers, so people who have cancer and their carers within AGITG, and the consumer group is always saying to us, the clinician scientists, they're always saying, just ask us, just ask us. We actually, most of the time, 99.9% of the time, patients will say, yes, please, I'd love to help you. Very rarely do they say no. And sometimes we've had trials which have involved quite difficult procedures for people, like maybe serial biopsies, for example. So that's quite a lot to ask someone, do a biopsy at the beginning and then another one partway through treatment and then another one at the end of treatment, for example. And the people that we work with who act as our consumer advisors say, absolutely, you go ahead, you do the best research, and you just ask us, because most of the time people are willing to go out of their way to help us, and we're very, very grateful for that.
And I think in turn the patients are really very grateful to have people such as yourself, and as we spoke to Tim last week, who have that combined passion for working with people, but also with that research mind of, okay, well, how can we think outside the square and look to the future and improve the treatments for people with neuroendocrine tumours, but cancer more broadly as well. So I wanted to raise a term with you, knowing that cancer and medical practice within cancer has heaps of jargon and acronyms and things that aren't necessarily obvious to lay people. There was a term that came up recently in another talk that I attended that talked about basket trials, and the reference was that these could be quite useful for people such as people with neuroendocrine cancers. And I wondered if you could tell us what is a basket trial and how these sorts of clinical trials could be relevant for people with NETs.
Yeah, thank you, Kate. So probably the best example of a basket trial is where you have a biomarker, which is like a signal in the biology of a tumor that you can find, let's say, with sequencing. So let's say there's a biomarker that I can find by sequencing a tumor, and it doesn't matter whether that tumor is a neuroendocrine tumor or a breast cancer or ovary cancer. It could be any of those, but it just has to have this biomarker. Let's take an example of, let's say, mismatch repair deficiency, or HER2. These are very common biomarkers which are talked about in cancers, and maybe we could screen a whole different all different types of cancer and put them in one basket to be tested for that biomarker. So that tends to be what we call a basket trial. And then we could have different baskets. So we could have a basket for HER2 positivity and another basket for another molecular change. And these sorts of studies work particularly well in what we call the tumor agnostic landscape. Now, I just want to tell you just one wonderful story about this, which has been very successful. So mismatch repair, what that means is that some tumors lack the ability to repair DNA damage, and it makes them very, very sensitive to some of our chemotherapies, like platinum-based chemotherapies, but also may make them sensitive to immune therapies because they're more able to generate an immune response. Now, in colorectal cancer, which is another cancer that I work on, about 7% of people have one of these tumors with this mismatch repair defect in it. Also, in people with endometrial cancer, some people have mismatch repair defective endometrial cancer. In pancreas cancer, there's some of those as well. And probably in some quite high-grade neuroendocrine tumors, we may see this, although it's very poorly studied in neuroendocrine carcinoma because of the numbers, and that's part of the point that we're talking about. But if we had a basket study where we could put all of those different people with different tumors, but with this one common biomarker into a study of immune therapy, that might be really useful. So that tumor agnostic study of immune therapy in mismatch repair deficient cancers, regardless of their origin, yielded a positive result. And so it's now become accepted practice. Hasn't quite translated into government funding for the medications yet, but it has become standard practice that we should look for these signals in as many tumors as we can. So that's an example of, it was a basket study that came up with this idea.
So it's looking for a feature of a tumour that's not necessarily related to the type of tumour that it is, but it might have in common with other sorts of cancers, so that you can look at them as a whole group.
That's correct, yeah.
So because it's a game of numbers, isn't it, where, you know, to prove a concept in a clinical trial or in research, you really need to have a lot of people responding in a similar way.
Exactly. And so for rare cancers, it's very difficult to just do a study on this subtype within neuroendocrine tumors, for example, because that would be such a small number. But if we had a basket study that allowed any tumors with this particular biomarker in, then we could actually test those very small subsets.
That makes lots of sense to me, and I hope that makes lots of sense to the people listening. I think that you explained that beautifully, so thank you. I wanted to move on to another concept, and again, I watched a video that you did very recently, and you talked about something that I thought was, again, really relevant to our patients, and that is about patient-reported outcomes and the role of looking at these in clinical trials. So I guess, from my understanding, clinical trials are often looking at the length of time that people are alive after they commence the clinical trial if they've got a cancer. But from what I was hearing you say, that it seems that we're thinking a bit more broadly these days. Can you tell us a bit more?
Yeah, so we've come to realise, and I have to admit, I think we've been a bit slow to realise as clinicians that patient experience of our treatments is very, very important, and we should be recording it. For too long, we did clinical trials of drug A versus drug B to find out which was best in terms of survival, as you say, but we neglected to record how people felt during the treatment. That's terrible. And we have been, severely criticized for running studies like that without any feeling as to how it affected people having treatment. So that is, like, I'm pleased to say in 2020 it would be unforgivable to not have some documentation of patient experience in a clinical trial. So there are some crude ways of doing that, like with quality of life indicators, but patient reported outcomes are a little bit more than just filling in a quality of life form. It's more about exactly what patients report. And sometimes the difficulty in doing this research is sometimes it's very qualitative. And of course, as researchers, when we're trying to work out whether drug A is better than drug B or intervention A better than drug intervention B, we want to know quantitatively how much better it is. And we're not very good really at looking at qualitative indicators of effectiveness and comfort in treatment. So we have in AGITG, we have established a collaboration with a quality of life research institute so that we do this better, and our consumers are saying, well, you really need to do this much better because patient experience is really important. So we acknowledge that it's very important, and we've been bad at doing it in the past, so we need to really get it right. I'm really proud to say that we're now even starting to run trials that focus almost exclusively on the way people feel during treatment rather than whether the treatment works better. A really good example is from a researcher at the University of Sydney, Professor Jeanette Vardy, and she has found that a medication that is actually used for blood pressure, I think, in Japan, actually prevents neuropathy, that is damage to the nerves in the hands and feet that happens when people receive some chemotherapies. And she's been testing this medication and finding that it helps people. And we're going to run a high-level clinical trial using that medication. And it has no commercial interest to anybody at all. It's not going to make anybody any money, but it's going to help people who have to receive this particular chemotherapy. It's going to help them have less side effects from it. It's just so important. And as you might be about to say, you can just see that it probably will make the chemotherapy work better, won't it? I mean, it's not rocket science. If you're able to tolerate it more and you get less side effects, you can probably have better and more intensive chemotherapy. So it may well actually do what we were trying to do in the first place, which is make people live longer. But that's just a wonderful study that it is our responsibility as academic researchers to get funding to do these kinds of trials and to run them. We're not going to get money falling out of the sky from a pharmaceutical company to do those sorts of things. We need to raise the money ourselves to do something important. And the Neuroendocrine Foundation and the GI Cancer Institute, which are both sort of the both charitable institutions as well, support the kind of studies that we do. And that's a really wonderful support that we receive from the community like yourselves.
Well, that's really amazing to hear about that, Lorraine. And I can just imagine the impact for people of if we were just thinking about Jeanette Vardy's study on peripheral neuropathy, having spoken to heaps of people with neuroendocrine tumours who have peripheral neuropathy, and thinking that perhaps the future might be, if we are able to treat their cancer successfully, maybe we can also help them feel better in the process, which seems a really great thing to aim for. There's a project that we've been working quite a lot on over the last couple of years, and we're hoping to do a Facebook Friday focus on it fairly soon, which is the Planet Registry, which is all around patient-reported outcomes. And patients actually have an app that they can put their record their experiences, and like you said, it's difficult sometimes to put a score on something. It's having had pain sometimes. When someone says, "Oh, what is it out of 10?" It's really hard to put a number on these things sometimes. But I guess when we're looking at bigger groups of people, the numbers really speak, you know, because you can put a bunch of numbers on a graph and say overall these people seem to be more comfortable than this group of people. And yeah, so anyway, it's a work in progress, but it's really lovely to hear that being a focus, that being an important area of focus for AGITG and the medical field generally. I think patients need to know that the doctors who are treating them are really focused on and really striving to have them feeling as well as possible. So yeah, thank you. I wanted to drill down into a particular study, and there was a comment in the comment section asking if researchers are still looking for people to do clinical trials on in nets, and that person was talking about their particular situation. And I guess you know, we touched on this last week with Professor Tim Price, but I'd be maybe interested to hear your comment on it as well. Just in terms of the diversity of neuroendocrine tumours and the types of trials that are available, but also wanting to talk about a particular study in neuroendocrine cancers called NABNEC. So I'm wondering if I could give you that double-barreled question of how would someone who lives in the country know whether there was a trial that was going to be appropriate for them?
Yeah.
But also if you can tell us about that particular study.
So thanks, Kate. I think you've pointed at one of the problems that we've had as clinical trialists throughout Australia is that the information highway for patients to find trials is pretty poor, and we're trying to improve that. The Clinical Trials Alliance of Australia, that's one of their main things, is to try to get the information out to patients better. At the moment, we have a very fractured system. In New South Wales, we do have an app, and I think in Victoria there's a similar thing where you can find a trial that might be in Victoria or New South Wales. There is a national clinical trials database that you can access online, but it is fairly hard to interpret for a consumer, I think. It's not in lay language. It's really designed more for people who are doing trials to work out what trials are already open rather than for patients. So you're absolutely right. I think this is an area that we need to do much better. And with the kind of technology that's available now, there's really no excuse. But I do believe it probably needs to come down from the federal government really to provide for all Australians some better information about accessing studies. You're absolutely right that neuroendocrine tumours in particular are a very heterogeneous group of tumours. So even though we kind of bunch them together, they can be very different. So many of you on the call will understand that a low-grade neuroendocrine tumour can be very indolent and you can live with it for a very long time, sometimes with no treatment, sometimes with octreotide analogues, injections once a month or so. So sometimes they're very indolent. On the other end of the spectrum of neuroendocrine tumours is what we call neuroendocrine carcinoma, which is what the NABNEC study is addressing. And that is for people with very high-grade neuroendocrine carcinomas. They're much like what we call small cell cancers in other tissue types. So in lung cancer, this particular tumor type is often called small cell lung cancer. And it has a very poor prognosis in contrast to low-grade neuroendocrine tumors. And the treatment for neuroendocrine carcinoma is very traditional treatment. It's actually exactly the same treatment as we use for small cell lung cancer, and it's a combination of two chemotherapies called carboplatin and etoposide. What the NABNEC study does is look at a different combination of chemotherapy. We're looking at carboplatin with nab-paclitaxel or Abraxane, which is a drug that's used in pancreas cancer. And this trial is only for people with neuroendocrine carcinoma that's of gut origin, not for those who have lung cancer. And it's quite an attractive trial, I think, for a number of reasons. The first one is that probably nab-paclitaxel is a bit more tolerable than etoposide. It's a bit nicer to have. And the second thing that makes me want to promote the study is that we've currently got about 50 patients enrolled on the study, and we're hoping to have about 80, so we still need more people. But we're doing some really, really important translational work, and by that I mean sort of investigational biology work on the tissue samples from people who have joined that trial, because we know so little about neuroendocrine carcinomas, because, and I know this is going to sound quite confronting to some people, but because people with this particular subtype die quickly, we don't get a chance to get much information from them. And so, you know, on behalf of those people who have died, we really need to work harder to work out what underpins the biology, what makes some cancers more sensitive to the nab-paclitaxel rather than the etoposide, or vice versa, so that we can make treatments better and maybe have selective treatments depending on the biology of the cancer. So neuroendocrine carcinoma is probably the only one of the neuroendocrine phenotypes that we would call a cancer. All the others we deliberately call tumors because they don't really behave like cancers so much, but this one does. Yeah.
Well, thank you, Lorraine. And if someone was watching this video and they have a diagnosis of neuroendocrine carcinoma from the gut, how would they get more information about this? And this is a Dorothy Dix because I know the answer,
Yeah.
just so that people hear.
So we actually had the GI Cancer Institute has a website. So AGITG and GI Cancer are the same things, sort of two organizations that work together. One is a charity and the other one is a working scientific organization. So we have a website called gicancer.org.au, and you can find the information there. You'll also find links to the information on the Neuroendocrine Foundation website. So you can find them there, and you can always email me, email Kate. We'll try. I actually receive quite a lot of inquiries from individuals, and I'm always happy to pass them on to the right people. So it kind of doesn't matter how you do it, but I think all of the people that I work with in the trial space are always trying to work really hard to reach out to people like yourself if you're interested in something. So we will try and answer those questions, emails, phone calls.
Thank you. And yeah, people, you're very welcome to get in touch with me about that study. And I think the other thing that I would just draw out from that is that it's sometimes hard to know. A lot of people don't know what grade their tumour is, whether it's a grade 1, whether it's a grade 2, whether it's a grade 3 well-differentiated neuroendocrine tumour, as opposed to a neuroendocrine carcinoma. So you know, this is something that we are constantly encouraging people to find out. So when you're talking to your doctor, it's okay to ask, well, what grade was my tumor? And, you know, they should be able to give you an answer and maybe even get a printout of your pathology so that you've got that information in your folder. And so when you hear things like this study, you can look at it with a little bit more information about your own situation, and you'll know a bit more about whether that's relevant to you and your situation or not. But I think also really importantly to talk with your own doctor. It's okay to ask about, you know, are there any clinical trials out there for me? You know, have we looked at clinical trials? Has my case been discussed with a multidisciplinary team meeting where they could assess whether a clinical trial might be, you know, a potential option for me? So they're, I think, all really good questions to feel confident to ask your treatment team. I just had another question, Lorraine, and this is, I guess, more about the current situation with COVID-19. And if you could tell us a bit about the impact that that's had on clinical trials that are currently running, but also clinical trials that are in development. What's it been like for you?
Yeah, so I think most of the impact has been on clinical trials that have not yet started. Those trials have been slowed down in terms of their starting up. So I think that's probably where we have seen the most impact. In terms of clinical trials that are already running, we have made an argument to the government and to the hospital executive that those trials need to stay open for patients with very few exceptions. So, for example, the NABNEC study, we've kept it open entirely throughout the COVID time because these are people who would otherwise be getting treatment anyway. It doesn't, we're not asking them to have an additional thing. We're just asking them to have something different, which in fact, in the case of NABNEC is somewhat easier than the other treatment. So we have really worked hard to advocate on behalf of patients that our trials need to stay open, particularly, I mean, the hematologists, the blood cancer doctors, they have trials that are absolutely life-saving and it would be criminal to stop them. So we have argued successfully to keep maintaining treatment that would be considered to be a kind of standard. It would be standard to treat someone like this. So yeah, the trials that are in startup, where that's the term we refer to, trials that are being sort of developed and signed off by the hospitals and things like that, they have definitely been slowed down. So we have had a go slow on starting new studies. Yeah.
And so I guess that might mean the flow-on effect. Well, it's hard to know the future, isn't it, with this? No
Yeah.
one's got a crystal ball with COVID-19 in terms of what that will look like down the track.
And our international partners have been affected much more than we have to date. And so there have been some international trials that we've been involved in that have been suspended and in some cases stopped, not because of Australian issues, but because of international issues.
Okay. So I guess probably the take-home message is that it's still worth asking your doctor, and
definitely.
If you're being assessed for a clinical trial that's in progress at the moment in Australia, that seems like it's still a fairly solid plan, but it might be that there's a flow-on effect from this slowdown, that comes down the track.
Yes, I think that's right.
Yeah. Okay. Thank you for that update.
Okay.
I had just one last cheeky question, and again, if there's any last minute questions in the comments, then feel free to put them in. But yeah, as I said, this is a little bit of a cheeky question, and it was one that we might have discussed with another oncologist on another week, and they had to take it on notice. But I wondered, apparently crocodiles don't get cancer, and they live to be very old, and they're certainly not in a sterile environment where you would, it's a bit mysterious. Well, why don't crocodiles get cancer? And is there anything we can learn from crocodiles that might mean that we could avoid people getting cancer too?
Yeah, I actually don't think it's a cheeky question at all. I think it's actually a really, really good question. I have learned from being a scientist for a few years that when people laugh at you at the start, it's often they're onto something because it's something very unusual that people haven't really thought about. So I think the fact that an organism like crocodiles has avoided many diseases that have caused the extinction of other species is very important. Crocodiles and reptiles like crocodiles have survived many, many rounds of disease and disaster because of the way that they're built. I mean, partly because they've got very, very thick skin that avoids radiation and so on. They live in a relatively small environment. They don't travel very far, I understand. And they probably have very interesting gut bacteria. And I think the gut bacteria, or what's called the microbiome, is probably going to be the secret to this story. And it really, we've scratched the surface of the microbiome in humans. There is some amazing science about the microbiome in cancer. There are some experiments that do something like this, where you have two animals, let's say rats in this scientific experiment, two rats, they both have the same cancer that's been injected at the same time, but for whatever reason, one rat is doing better than the other. They can't really work out. They were identical rats as far as they were concerned. And then they transplant the poo from one rat, the rat that's doing well, to the rat that's doing badly, and all of a sudden the rat that was doing badly does better. So there's something about the gut microflora that changes the body's ability to fight cancer. It probably is related to the immune system. So I've stuck my neck out and I've been laughed at. I'm actually trying to create and run a clinical trial in pancreatic adenocarcinoma, not neuroendocrine tumours, but in pancreatic adenocarcinoma, looking at the microbiome and immune therapy in people with pancreas cancer who are going to have an operation. So I want to give people with pancreas cancer immune therapy and chemotherapy prior to surgery and look at their microbiome before, during, and afterwards to see what changes happen. Yeah, so I don't think it's a cheeky question. I think it's very important.
Wow. So are you saying that sometime in our potential future we could be taking poo pills as part of our
Could
cancer
have poo
treatment?
transplants, fecal transplants, and I think there have been some human experiments using fecal transplants. Yeah.
Well, that's something for us all to look forward to, isn't it?
I know it's just mind-blowing, isn't it? But that's very, very interesting.
And it's lunchtime again, so apologies
But
to everyone.
how wonderful to be able to learn from crocodiles about
Exactly.
cancer in humans. I think that's a really good model for science across different disciplines. That if we stick to our silos, we're not really going to achieve as much as if we look outside of our silo to other things.
It strikes me, Lorraine, that this good researchers need to be scientific, but not only that, they need to be creative. But then not only that, they need to be really empathetic, and imagine what life is like for people who are living with these cancers. And I think what you've shown us today is someone who's combining all of those attributes.
Oh, thank you.
Really beautifully. So can I just take this opportunity to thank you for joining us. I wanted to finish by telling everyone a story about Lorraine. And Lorraine, I'm sorry for I didn't warn you that I was going to tell a story, but I actually met Lorraine about 5 years ago at a meeting which happened just a couple of weeks after I started with Neuroendocrine Unicorn Foundation, as it was back then. And I was a very green, nervous person who knew a lot less about neuroendocrine tumours back in that time. And I was at this meeting feeling fairly overwhelmed, and I was talking to Lorraine during one of the breaks, and one of the things that stuck out to me was that Lorraine was very happy to talk to a nurse, and a very green nurse at that, which is not always the case when you're in a room full of professors and very smart people who live very much in their cerebrums. But one of the things that I was asking Lorraine about, well, what is it that you enjoy about working with people with neuroendocrine tumours? And the thing that Lorraine said to me, and it's stuck with me forever, is that Lorraine really enjoys developing a relationship with people, often over many years, and the opportunity to get to know people and get to hear about their grandchildren and get to see them, grow throughout their life. And the fact that this is a cancer that people can have for many years is actually something that she really treasures. So that really stuck with me. I thought, well, if there's a doctor who really enjoys spending time with patients, I think that's the kind of doctor that I want to talk with. So thank you, Lorraine, for being that person and for joining us today and talking with us about some of the really interesting research that's in the pipelines. As always, for everybody who's watching, talk with your own doctor about your own situation. We mentioned this. There's such an incredibly diverse group of tumours that, what's going to be suitable for one person may not be suitable for the next. So, Lorraine, I've got a couple of other little housekeeping updates that I'm going to tell the group about now. So you're welcome to stick with us for that one, or if you need to leave, then you know where the red button is. But thank you so much.
Thank you so much, Kate. It's been my pleasure. And you're right, the favourite thing about my job is working with people. So thank you. And thank you. Nice to meet you all. I'm sorry I can't see you.
Thanks, Lorraine.
Okay, bye now.
Excellent. So I can see that Lorraine has left us. So that just gives us a couple of minutes to do some very brief housekeeping. The first thing I wanted to say, just to give you a reminder about, is that we've got our Zoom meeting for our online support group this afternoon. And if you're in the Melbourne time zone, that's in just over an hour. It's going to run between 2:30 and 4. So we've got quite a few people who have indicated that they are keen to attend that one. So I've sent every person who has RSVP'd a private message. If you're not my Facebook friend, the private messages can be a little bit hard to spot. So if you're unsure, if you think that you should be coming along to that group and you can't see the details, just send me a private message. Now, I rarely say send me a private message on Facebook because, as most of you know, please don't ask me net nurse questions. So I can't provide you with information and support about your cancer situation over Facebook Messenger, but certainly for details like group meetings and things like that, that's the tool to use. So if you're unsure about how to access that meeting and you wanted to come along, send me a private message on Facebook up until 2:30 and I will shoot through the link for you, and we're meeting via Zoom. So that's the first thing. And the second thing was that July seems we've struck the jackpot with guest speakers, and we're really excited that we've got a guest expert joining us next week, Professor, I think, Dr. Judith Lacey. I can't remember if she's a professor or a doctor. There we go. There's my empty brain that also thinks it's Wednesday somehow. But Judith Lacey is an expert in integrational medicine. So she's not only an oncologist, but she's an expert in using integrative medicine within the treatment of cancer. And so one of her areas of expertise is an area that's a hot topic always in our online group, which is medical cannabis. We have a lot of questions and a lot of discussions in the group, and I'm really excited that we're going to have a chance to sit down with Judith next Friday to really ask her all of those tricky questions and get her to explain how it works, what the different types are. I want her to tell us whether people can drive. I want to know about side effects, and clinical trials. So I'm really looking forward to that session next week. So more information and a spot to ask questions will come up in the Facebook group early next week. I'll post about that conversation. But yeah, maybe put it in your diaries. And as always, we will record the conversation, so you'll be able to watch it later if you can't be there at 1 o'clock on Friday. The other thing I was just going to mention is that we have started putting our Facebook Friday videos onto YouTube, knowing that not everybody's on Facebook, and there's good reasons for some people not to be on Facebook, and that's absolutely fine. And we wanted to not exclude people because, just because they weren't on Facebook. So these videos are going up onto YouTube each week. So if you've got someone in your life who's not part of the private discussion group who might benefit from watching these conversations, I will put the YouTube link in the notes. So look, I hope you all have a good week. The other thing I was going to say is that I had a coronavirus swab last weekend. It's not as bad as you might imagine. There's no gagging involved. When the guy who did my swab was an ambulance officer, so and he was doing some extra work to help out. I did it at the drive-through, which was with my husband, which was not really very romantic, but got the job done. We got the results on our 25th wedding anniversary, which was very romantic, but no gagging. So he just swabbed the side of my throat where the tonsils would be. So there was no gagging. The swab does go quite, you wouldn't realize how far your nostrils go back, but it does. Swab goes all the way back. It wouldn't be what I would do for pleasure, but it certainly wasn't something that would be like, ooh. And having had the test done, I wouldn't have any qualms about having it repeated if I was to get symptoms again. So I'm fine. I do not have coronavirus, and I'm really grateful and pleased about that. I got to practice my mask wearing technique inside my house this last week, so I've got that a bit more down pat. But I just wanted to tell you about that experience because I know a lot of people are a little bit anxious about that, and so I thought maybe it might be helpful for me to tell you what that was like for me. So anyway, you know how to reach me via the NetNurse line or via netnurse@neuroendocrine.org.au. So if you've got questions or concerns or things that you need help with, then you're welcome to give me a ring. Normally it's 1 to 2 days before I can get back in touch with people. So if it's an emergency, then call your doctor or your local health service. But certainly in terms of access to information about neuroendocrine tumours and support, I'm really happy to hear from you. So I'm going to stop blabbering on, let you get on with your lunch, having talked about fecal transplants and poo pills and all sorts of exciting things today. I'll talk to you next week. Take care, everybody.